As the psychedelic renaissance begins to evolve the field of mental health, traditional approaches to therapy are intertwining with novel methods, pushing the boundaries of what's possible in healing and transformation. Integration therapy, particularly in conjunction with psychedelics like psilocybin, is emerging as a promising path towards holistic mental well-being. Join us as we unravel the future considerations surrounding this dynamic interplay between therapy and psychedelics. We're delving into the ethical, societal, and medical implications as these therapies pave the way for new horizons in mental health treatment. Our guest today, Dr. Louis Enrique L. Liogier-Weyback, the president and founder of Dr. Jane, South Florida's most professional and discreet concierge medical cannabis practice. He's also a retired neurosurgeon and was one of the first physicians in the world to complete his Master's of Science degree in medical cannabis science and therapeutics from the University of Maryland School of Pharmacy. Needless to say, he's uniquely qualified on many fronts to dig deep with me tonight and discuss the potential challenges and ethical dimensions of integrating psychedelics into therapeutic practice.
You're listening to the MycoGeeky Podcast, a podcast that inspires people to grow mushrooms at home to improve their mental, emotional, and physical health. Most people call him geeky, and he is a passionate mushroom cultivator, advocate, and educator. Every week, he sits down with fellow cultivators, mushroom educators, scientists, and therapists to discuss the various ways people can approach mushroom cultivation and how mushrooms can be used to improve their lives.
All right, what's up, guys? Welcome to the MycoGeeky Podcast, the podcast that goes deep so you guys can level up your at-home mushroom cultivation games. I'm your host, MycoGeeky, and we got a good show for you tonight. We're live right now. Woo! Check it out. It's happening right now. If you guys came to my house in Akron in the basement, you'd just see a guy in front of his laundry machine doing it right here, right now. That's what we're doing. All right. So tonight, got a cool guest. We're going to do, this format's going to be a little different. We've been talking about going through some scientific literature. Dr. Rick and I have been talking about this. When you're in med school, they call it journal club. So we're going to do something like that. We're going to just kind of walk through. There's a new piece of literature that came out about a month ago. It's pretty exciting. It's pretty important. And he brought it to my attention and said, hey, we should probably talk about it. So we're going to walk through that. First, I want to shout out all my Patreon supporters. Really appreciate all the support I'm getting on Patreon. Love my Discord mods. Really just this week, I've really been feeling really connected and really can't say enough about this community. So thank you guys. Also, a lot of people are asking about the Mutant Grow Along. That's coming up first full week of December. So I think it works out to really look more like the second week of December. Stay tuned for that. I will be announcing it on the podcast. I'll be announcing it on my social medias on the Discord. So if you are in any way following me and connected to me on social media, you'll officially know when it's happening. So stay tuned for that. That is going to be fun. All right, there it is. There it is. The Mutant Grow Along is going to be fun. I got a lot of people asking if, hey, I already have a few of these mutants, but I'd love to do the grow along. Maybe you got the cultures, you've never worked it. That's absolutely cool too. We will be tracking all that in the Discord. So there's a special mutant grow along channel as people get their cultures and they start expanding it out and all that kind of stuff. That's where people will be posting what they're up to, when they spawn to bulk on stuff, just tracking progress, asking questions, answering questions. That's where all that's going to happen. So I'm really excited about getting that going. That should be a lot of fun. What else we got going on here? Oh, yeah. So I briefly mentioned last week, the kid in Connecticut got busted for pretty fair scale grow operation, and a lot of people wanted me to talk about it. I don't really know what there is to talk about. I am, if I'm going to reiterate, it's going to be something that my buddy Ed Grant told me, which was, he said he thought there was a lot of people out there paranoid about the DEA, paranoid about, law enforcement, drug enforcement, all that kind of stuff. And he goes, you want to know who people should be worrying about? They should be worrying about ex-girlfriends and disgruntled ex-employees. And if you guys follow that story, you'll know that is pretty spot on. Now, all I'm here for people who are growing mushrooms in their homes for themselves, for like the healing potential that I and many others believe psilocybin holds. If you're going beyond that, that is on you. I'm not here endorsing that. I'm not here advocating for that whatsoever. I do know people are going to be out there doing that as decriminalization efforts continue in various regions around the country. Fully expect to see more of that stuff. But I don't really know what else there is to talk about that. I wish him well. I hope he gets a very light sentence. I hope he gets good representation. And I look forward to finding out how that unfolds. Moving on. So we had we've had an interesting couple weeks on the Discord. There have been some interesting characters coming out of the woodwork, and it's really highlighted for me how important this whole mental health conversation really is. You can't just take some mushrooms and expect all your problems to be solved. It's real easy. It's real easy to think that's all it takes. We are all huge advocates of this medicine. But in many instances, there's a lot more to it than that. So that's why tonight's conversation is so important. So we're going to get into that. He's been on the show before. We got him back tonight. We're really lucky. He's got a lot of stuff going on in his life. I twisted his arm just enough, and we got him back. So let me welcome to the show, Dr. Rick. What's up, man?
Hey, what's going on? How are you, man?
All right, Bob Ross without the afro. I like it. What is on that scrub cap of yours? Is that mushrooms?
So, yeah.
Oh, yes. I like it. I wonder how many surgeons are actually walking into the OR wearing that cap.
Not many.
Probably not many. Not yet.
Yeah.
Not yet.
Yeah. No. It's unfortunately the medicine in general, but I mean this, but especially the surgical subspecialties are incredibly conservative.
Yeah.
And things move extra slow there. But yeah, no, I think it'll eventually get there one day.
I like it. I like that. All right, so you brought this paper to my attention, and I think for everybody watching, it's linked in the description. You can go to the link, you can pull this thing up, you can follow along, or you can just watch the podcast. It's all going to be right here, however you guys like to learn best. It's called Back from the Rabbit Hole, Theoretical Considerations and Practical Guidelines on Psychedelic Integration for Mental Health Specialists. So to be clear, this paper was written for the mental health professions. Psychiatrists, psychologists, clinical therapists, social workers, people in that capacity. It's not specifically written for us, but we're going to talk about it tonight because it's important. Because as you and I were talking earlier, this is an important paper, right? This is why you brought it to my attention.
Absolutely. And I think to your point, or why would it be important for, in particular, this audience or the intended audience of this podcast? Well, ostensibly, these are the folks that would at least potentially be the patients. So it's really important for you guys to understand not only what the pipeline currently looks like, but what could look like. And pipeline, I mean treatment pipeline, so to speak. So like what happens when you first establish contact to the time where your therapy's up. But I also think that it's extremely important to go over this stuff to really highlight the limits and potential pitfalls of this therapy, because it is extraordinarily new. not so much using psychedelics for mental health purposes, but making a concerted and organized effort to replicate this type of therapy, which when done properly is extremely beneficial, when done poorly can be very detrimental. So
That is great. That is important. I think for me, my takeaway from first kind of perusing this paper was, wow, these guys finally said, hey guys, it doesn't look like psychedelics are going anywhere. It looks like this is going to be a thing. So we should probably try to get ahead of this. And so for that reason, this being published only a month ago, even though the psychedelic renaissance is supposed psychedelic renaissance is 2-3 years old, it shows you that it's becoming all the more a real thing, and that finally it can't be ignored. These people got a whole consortium of people together. They had I'm assuming some sort of conference. There was a whole to-do about, let's gather a lot of people around this topic and figure out an initial framework.
yep.
Wow, it's only just starting.
I think one of the things that, I mean, we'll obviously get into it when we go through it point by point, but I think one of the things that they did well are, to their credit, they approached this with a very much, harm reduction first approach, which is very different from how Western medicine has traditionally approached this, in a very, sterile, white room, white coat manner that frankly made people that weren't insane go insane.
Right.
So,
yeah, and there's what to that point, when we get into it, there's one section that was particularly interesting to me. I think we'll spend a fair amount of time on, but let me just quickly read the little preface to this so everybody kind of knows what this is all about. And this is a decent size paper. I'm used to 5-6 pages. I think this is close to 20. We'll see how we do getting through it. I don't want to bog people down too much. I want to keep this kind of a little broader stroked. And there's sections that get a little more heady and a little more specific about therapeutic models and things like that we maybe might or might not need to get into. But so here's the overview. This is like page 1. The growing interest in and prevalence of the use of psychedelics, as well as the potential benefits and negative consequences associated with psychedelic experiences, creates a need for mental health specialists to be able to provide adequate and effective intervention regarding the content and consequences of these experiences. That is psychedelic integration. At the same time, current graduate training in psychiatry, psychology, psychotherapy, counseling, etc., fails to adequately prepare professionals for such interventions. So, to quickly paraphrase, there needs to be interventions. Current training doesn't allow for them. Thus, this paper. This project was conducted by means of literature review as well as roundtable discussions among project participants, leading to a consensus on the guidelines' final scope and content. Drawing from the outcomes of this project, the article presents proposed comprehensive guidelines covering both theoretical and practical aspects of psychedelic integration that are intended to serve as a resource for various mental health specialists who may encounter individuals in need of support considering their psychedelic experiences. They finally realized, what I have to imagine is happening is these professionals are having people show up to therapy sessions going, so
Yep.
I tripped balls last weekend. So I tried ecstasy because I read an article. I tried this because I read an article, and my friend did this and he loved it, so I tried it. So it's finally dawning on them, like, they're ill-equipped to talk about these very profound experiences. So I commend them on this. So they say these guidelines encompass clinician-friendly information on the effects of psychedelics, a definition of psychedelic integration, the general theoretical considerations linked to utilization of psychedelic experiences in clinical practice. A simple model organizing the course of psychedelic integration practice, as well as an overview of the current models of psychedelic integration, along with a selective presentation of basic and specific interventions derived from various psychotherapeutic approaches that can be employed in the practice of psychedelic integration. I love this. Basically, the end is saying, and we know you need something to do right now, so we tried to propose like some ideas for you guys, since we know you're trying to tread water on this stuff. I can only imagine being a straight-laced psychiatrist or a straight-laced, clinical social worker, taking care of somebody, and all of a sudden they come back. They had the trip of a lifetime, profound spiritual experience, and they come back and they try to tell me about this, and I'm just sitting there like, what am I supposed to say now? What do I do with this? You just had what? You just like talked to God for 8 hours? I don't know how to respond to that. So this paper is really cool. I'm glad. I have to assume that many very serious therapists and psychiatrists this will hit the radar and they'll go, okay, I better check this out.
I hope so.
I do too. So they start out with a background, and I don't need to get into a lot of this, but where it got interesting for me is the section on psychedelic research and therapy, which a lot of people watching. So this was also fascinating. I was like, wow, a lot of this stuff that they're doing in the beginning is laying a background or kind of contextualizing stuff that all of us in the space already know about. It's common knowledge. It's part of our folklore, whatever you want to call it. But anyway, so they sort of walk through the early history back in the 50s, 60s, 70s, all that stuff. And they talk about the, imposed hiatus, all this good stuff. But this section really got me here. They say applied research on psychedelics, however, is not merely a present-day phenomenon. Between 1940 and 1970, these substances were the subject of numerous studies focused on their clinical use as an adjunct to pharmacological treatments of alcohol use disorder, psychosis, and neurosis. And then they link the paper, and they say, so this is, I love that they're just, the people who wrote this paper, I think they maybe are of our tribe, because they're really giving everybody all sorts of reasons to really consider this stuff. They're basically saying 40s through the 70s, we were doing this stuff and it was looking good. And then legally imposed hiatus. Now we got to take a break. So here we are, we're back to it. So then they go on to say,
quick interjection for everyone listening. They're like, well, why the hell is that important? I will tell you that from my perspective as a clinician, the vast majority of us, meaning physicians, don't know any of the history with psychedelics. It is not only not talked about, it's actively avoided. And so very frequently in my day-to-day practice where I see patients, I interact frequently with doctors who are very curious about this, and because I'm kind of vocal and out there, I'm usually the person that gets approached. And I start telling them about all this stuff. I'm like, hey, did you know this? Hey, did you know this? And it's a complete blank look. They're like, wait, what? What do you mean we legally gave psilocybin to patients? I was like, yeah, like in Baltimore, in PG County. And yeah, Hopkins was part of it. Hey, did you know that Bill W., of Alcohol Anonymous, originally intended for LSD to be part of the treatment algorithm? And it was only...
Yeah, they didn't know that one, I bet.
Yeah, and it was taken out when they, aligned themselves with the evangelicals who said, no, we don't want any mention of drugs. It's like, so it's really important, just kind of, setting the framework why it's important to tell clinicians this type of stuff, because you're really trying to sell them on the fact that, hey, this isn't actually anything new. This isn't some new scary therapy. This has actually been fairly fleshed out over the last, several decades. It's just unfortunately been part of a really, really, really well orchestrated smear campaign.
I mean, there's no other word to call it. That's specifically what it is. Yes.
Well, it's hard to not sound like a conspiracy theory.
Well, it's
But when
not
you
even a
know the stuff,
conspiracy. I mean, there's no way that's not what it was.
yeah,
If
no,
you
no,
even
it's
remotely
documented.
look at it. Yeah.
It's in the Library of Congress. But I'm just saying, like, it's hard to especially in the age of conspiracy theories. It's hard not to make that sound like,
Yeah.
hey, the government experimented on all this stuff on this unsuspecting public and then covered it
Yep.
all up.
Man, that was
Or
like when
whatever.
I had Rachel Harris on, and she was telling the story about how Carl Jung, right? Big deal.
Yeah, yeah.
Since if we're talking about therapy, um, all of Jungian psychology, which if you know anything about it, is a lot about images and symbols and interpreting dreams and all this kind of stuff. Apparently, what got washed out of history is that he had an affair and had a lover who helped him experience psychedelics. And it
Yeah,
was likely the psychedelic experiences that aligned him with this theory.
yeah.
But the
I
family wanted that all erased because it didn't make him look good. It didn't make the family. It was a shame on the family, all that kind of stuff. So this gets washed out of history. I mean, I just,
bullshit.
the longer I'm in this community and I'm talking to people and I'm doing my research, and I also read about the Al-Anon guy kind of having to make a decision to step back from the psychedelic space because of aligning with the religious right, and they saw it as an
Hmm.
opportunity to help the old drunk husband get his shit together type of thing. And yeah, now I am a huge fan of 12 step, by the way. I think it's one of the
Oh yeah.
few things that really works for a lot of people. Anyways, I'm definitely not bashing that. All right, so thank you for that. I think that's important. I have also worked in several hospitals where the culture, for some reason, seems to have a more negative attitude towards addicts. Some are more
Oh yeah.
progressive, some are much more traditional, and it's fascinating to see how the hospital really dictates a certain cultural attitude about people who are struggling with serious addiction.
Oh yeah. Well, I mean, just consider like what we were all going through right in the middle of the Great Recession, 2007 to 2010. Because what else was going on? Purdue Pharma and OxyContin.
Right.
You know, it's like, yeah. So I agree with you. It's a cultural thing that you can smell at certain
Oh my
hospitals,
God, yes.
especially when they walk into the ED and you're just like, oh, like, yeah, just because he's pain seeking doesn't mean he's not in pain. You know?
That's why I keep trying to tell everybody. Or I worked at a hospital where I had a lot of people that were ex heroin users,
Yeah.
and they were off heroin. Maybe they were on methadone. Maybe they weren't. Maybe they're completely off everything. But now they're like in their 70s, and let's say they break a bone, and they want to give them a Norco 5. And I
It's
go
like,
to the
come on,
doctor.
man.
Do you know anything? Like, do you understand this guy was on heroin for 8 years? You can't. I mean, I might as well give him a Tic Tac or a breath mint. Like,
Yeah.
it's not going to do anything. And they didn't care. The attitude was, well, they shouldn't have done heroin then. And I'm like, so is it a fifth vital sign? Do we care about this or do we not? What is it? So yeah,
Yeah.
don't get me started. I could do a whole. I'm sure you and I
Press
could both do
Ganey,
a
man.
whole. Yeah. Oh.
Press
Yes.
Ganey. Ruined
Yes.
medicine.
Yes.
For
Yeah.
for the people that don't know what we're
That's a whole.
referring to,
Yes.
everyone in healthcare is subject to Press Ganey satisfaction scores, and so it doesn't really matter, you know, how good you're doing for the patient. If the hospital doesn't hit its score metric, you didn't do your job.
Yeah.
So, yep.
Oh, it's so fun. Yes. Yeah. And the irony. Now I'll tell you a story. The irony is these metrics and these surveys and all this stuff, they're not even doing a good job of capturing an accurate portrait, because
No,
I have frequently seen the worst nurses get some of the most glowing comments.
because they know which buttons to push.
Yeah. Where
They know how to play the game.
they're just playing a game. 100%.
Yeah.
Yeah. All right. Sorry. So, okay, let's get back to this. So under this section of psychedelic research and therapy, which you guys can check out, so they're painting this picture about the history, and they're saying, so back then, in the beginning, this approach to working with psychedelics involved the repeated use of low to medium doses of psychedelics in the clinical context to facilitate psychoanalytic therapy. They said in parallel, another approach, psychedelic assisted therapy, or PAT, has also been developed, which more explicitly combines psychiatric and psychotherapeutic interventions. So here's the idea. Back then, it was not a foreign concept for a psychotherapist or a psychiatrist to say, just so people know, I'm sure many people in this community know this. If you see a psychiatrist, you go to them, you talk to them, they ask you a bunch of questions, maybe you take a test, you get a diagnosis, and then they prescribe you medicine, which they expect you to go home and take. And you'll get a follow-up, hopefully in an appropriate time interval, and hopefully you show up for it. And maybe you do and maybe you don't, but the medicine is taken out there, not when they see you. What was different here is it was more normal back then. It wasn't commonplace, but it was more normal that you would go to your therapist and they would say, I'm going to give you this pill now, and I'm hoping to use the effects of that in you to elicit a more therapeutic intervention process while you're here. That's what we're bringing back to the table. And that is what this article is about, is the idea that people are having these experiences. They're trying to kind of play their own therapist, figure some stuff out, and then now how do these clinical people in these clinical situations handle this? And then going forward, potentially, I'm hoping these same people start talking about how do we actually do this psilocybin assisted therapy, MDMA assisted therapy, ketamine therapy, whatever it is, where you're merging those things together. This paper is talking about just the integration process after the experience. So, okay, just that. Then they say, where is it here? Okay, so then they have a section, the need for integration, the need for psychedelic integration. And so they go on a little bit more, and they say, at the same time, there's a lack of formal preparation for mental health professionals, i.e. psychiatrists, clinical psychologists, psychotherapists, counselors, etc., who have increasing contact with clients having psychedelic experiences. They say several training centers have recently started offering workshops or certification courses on psychedelic integration, or PAT, and work is currently underway to establish multi-university postdoctoral fellowships and training programs in psychedelic therapy. However, to date, these are all postgraduate training courses and primarily in the U.S., which is unlikely to meet the growing demand. I thought that last little bit there was very interesting.
Absolutely.
They're already acknowledging this demand, this issue is gonna be freaking huge. And whatever little postdoctoral fellowships we have, whatever little training programs we have, it's not going to be enough. They're anticipating this growing demand is going to far outweigh clinical support. This is kind of like for people who work in healthcare. When Obamacare passed, I was like, yay, I'm a socialist. Obamacare, I want universal healthcare. Nowhere in Obamacare did it say where we were going to get the doctors, nurses, respiratory therapists, occupational therapists, clerks, radio
details.
They didn't figure out where the people were going to come from to take care of like an influx of 10 million people in the healthcare system. So that was kind of an oversight. But I love that this early paper is saying, so we don't, like, this is a real problem. I mean, it's subtly stated, but it's definitely going, this ain't going to cut it. We got to do more. So we're trying to write this paper so you guys got something.
So
I like that.
One of the things that I want to really point out to folks, because it's not immediately apparent unless it's an area that you're already working in. So the way things currently stand, if you can find someone to help you with psychedelic assisted therapy, that PAT. Number one, what that really means in layman's terms, or I guess what the what the similarity would be, or the analog
Mm-hmm.
would be, they're essentially the trip sitter. They're the person
Right.
that's guiding you through the actual experience. They're actually getting their hands dirty. And then you have a mental health professional, a separate person that's doing the integration therapy.
Right.
I don't think that's immediately apparent to folks that in the current the current paradigm, uh, that person is not the same person more often than not. There's the number of different reasons for that, but yeah, in an ideal world, you would have the person doing the screening, doing the therapy, like the psychotherapy, before they're doing their psychedelic, the same person guiding them through it, and then the same person doing their integration care.
Now,
That's in an
okay.
ideal world.
All right. So Dr. Rick says that's ideal. That's in direct contrast to what Rachel Harris found most of these spirit guides that she interviewed for her book,
Mhm.
Swimming in the Sacred. They all were very proud to say, we believe and support integration therapy. We, however, don't feel like that is our area of expertise. We
Exactly.
feel we are expert in guiding a trip and sitting for a trip. So now this is very interesting because is it possible for Western medicine, Western psychotherapy, Western psychiatry to somehow glean some of the wisdom from these trip sitters, these spirit guides? Because you're arguing, and I actually think I agree with this. For me personally, if I have to imagine I'm a person who isn't comfortable trying psychedelics on their own, and I feel like I need this whole support of Western medicine to do it, I do think I want the person who talked to me to help set, my trip, do my
Yeah.
set, discuss my, talk about the setting. The person who's prepping me, I want to be the same person doing my trip sitting or whatever you want to call that in a clinical setting. And then later afterwards, because what I don't want to do is have to like tell the story. I would
Exactly,
rather
because you're
you
gonna
be,
re-trigger yourself.
yes,
You're A, gonna re-trigger yourself, and B, you're never gonna get deep enough, because every time you get
yeah,
deep enough to get to that point, oh, it's time to see a new person, or it's a
yeah,
new phase of my treatment. Now I got to start the whole
yes,
thing over again.
yeah,
That's really why I think in an ideal situation, it would be that person that you already have that trusting relationship established, because
right,
that sets the environment for, I'm in a safe space, nothing is going to happen to me, and this person is going to protect me.
yes,
Because that is what psychedelic assisted therapy is in a nutshell, or at its
yes.
core instead.
Now, what gets me though, so she brought up, I think my favorite thing from that interview was that she had said that right now the psychedelic renaissance is being framed medically and legally, but
Mm,
it is not being framed spiritually.
correct.
And so for for me, I mean, I was raised in the church. I know what a preacher looks like. I married a Catholic. I know what a priest looks like. And I know that those people like to put on their garbs and they like to play the role, right? It feeds into just a deep history of spiritual leadership and all that. I'm not going to argue about that. So the question is, because I imagine that if I go down to Colombia and I'm cruising down a riverboat and I get off the boat and there's this guy and he's going to give me an ayahuasca ceremony and he's got all the stuff. And I mean, I could really get into that, right? And
Hmm.
that would feel really real. And I'd feel like I'm reconnecting to something ancestral and important and significant and meaningful. How do you take there is this
Yeah,
sort of
yeah, yeah.
disconnect for me, right? How do I get a psychiatrist, a doctor, who prescribes Lexapro sometimes and spirit guides other times? Do you know what I mean? This is an
Yeah,
interesting problem.
no, absolutely. So here's item number one. I fully acknowledge the fact that the way that we currently and have trained, the psychiatric and psychological therapists has been in almost direct opposition to the spiritual aspect. And Roland Griffiths, rest in peace, he talked a lot about this because it was very personally relevant to him. He was very much a straight laced, science only. I can't put the feeling in there because, again, medicine is an extraordinarily conservative industry. And that was a thing that he really had to reconcile. And that's why he wrote the paper that got so much attention in 2008 or 2010 about, bringing about mystical experiences. And why did this man who eschewed everything spiritual write this piece? It's because part of it is performative theater, part of it is setting the appropriate set and setting, but part of it is also acknowledging that that gives us profound experiences that are by definition ineffable. We can't explain these things.
Right.
And what is spiritualism, or what is religion at its core? It's a scaffolding of beliefs. I won't say virtues necessarily, but it's a scaffolding of beliefs on which we build our understanding of the world.
Yes.
So I do absolutely think that that's a vital part of this. Now, how do we get folks to make that conversion? I don't think that you can get anyone that's currently practicing to make that conversion, at least in a 5 or even 10-year span. I think this is something that has to be incorporated from day one. Like,
Right.
it has to be incorporated into the actual educational backbone of this. This is something that has to be like pounded into folks from the very beginning. Again, it goes back to, in Western medicine, we have very much wanted to separate the two. This is, I think, one of the only places where separation of church and state remained,
Right. Yes.
And it very much makes clinicians and hard scientists very uncomfortable to talk about emotions and spiritualism and religion.
Right.
It's like bringing up politics. You're just like, okay.
Oh, yes. But now, so I think that's even true for psychiatrists who are medical doctors. But right there, so people will ask this at work a lot. A lot of people getting prescribed psychiatric medication.
Mm-hmm.
Oh, where'd my camera go? Can you see me?
I didn't do it. I see El Gato, no signal.
Do you hear me?
Mm-hmm.
Oh, okay. Hold on, guys. Let me figure out where my camera went. Hold on. Give me 1 minute.
We need like a Tom and Jerry intermission. I'm looking at the comments. I'm scrolling back up a few minutes. I got your video back.
Alrighty. Ah, the good old lives. There's always something fun in the good old lives. Oh my goodness. All right. So what I was trying to get at is, right, and I don't know if I spend a lot of time explaining this at work, that, right, a medical doctor is looking at everything through the lens of pathology, a disease process. They are absolutely trained to look for disease. So if you're going to a psychiatrist, they're looking for a DSM-4 diagnosis. They want to see, are you schizophrenic? Are you bipolar? Are you both of those things? Do you have major depressive disorder? Like, what real pathology do you have? Do you have OCD? And then I can prescribe you a medication. I can start an intervention process with you. If you would just have problems and maybe none of that, then maybe that's the psychiatrist might not be the place for you. But what happens if you keep going to the psychiatrist? He or she is going to want to keep doing what they got trained to do, which is find a problem and prescribe a medicine for it.
To a man with a hammer, the world is a nail.
Yes, exactly. So I always say, look, first off, so many people get all their psych meds from their PCP. And I just say, hey, maybe for a very short period of time to bide your, to get you by, maybe here's some Ativan until you can see a psychiatrist. But they don't do that. They'll be on psych meds for 6 years and wonder why things aren't going well, and they never seen a psychiatrist in their lives. It drives me crazy that these PCPs keep doing this stuff. It's like
where it comes to a head?
Yeah.
When they get admitted,
right?
When they go for surgery, and their home meds aren't restarted, and then all of a sudden you have people developing withdrawals. You have people developing DTs because they've been on high dose Ativan for 19 years, but grandpa doesn't think that there's anything wrong with his 2 pills at night before he goes to bed. It's like, well, that's why he's seeing pink elephants right now. Happens all the time.
I mean, that's like
all the time.
Yeah. All the time. There's no communication about, without going on an absolute tangent, there's not enough communication. Somebody will start on a drug and then they'll go, it didn't work, and they just stop it. And there's no follow-up. There's no, we're catching most of that stuff in the ER. Like, oh, you just stopped that? You weren't supposed to.
Like that?
That's why you're here. Or did you tell your doctor that you stopped taking that blood pressure med because you thought you didn't need it anymore? Maybe just tell them, right? So there's this big problem, this disconnection between, and a lot of it's education on how getting dialed in on meds works. And people just want the doctor to just magically say the right amount, and they take it and they don't want to think about it. That's a lot of people. But that doesn't always work.
To your point about how allopathic physicians have traditionally been trained, yes, it's 100% in a systems-based or problem-based manner, meaning you don't look at the person, you look at what is the individual complaint. And I will tell you that is absolutely how it was for 80 plus years. There's been a much more concerted effort, really starting around like my generation of med school graduates, and my brother just graduated from med school, and I see it like just that much more in him 10 years down the line, where they're making a much bigger push for a holistic approach.
Right.
But the biggest convincing thing, I can't think of an eloquent word for it, that really convinced me to change the way that I was practicing was me being a patient and having all of these issues where I was seeing a GI doctor for severe IBS. They thought, do I have celiac disease?
Right.
Then seeing a neurologist for muscle pains, then seeing a neurosurgeon for other pains, and then seeing all this. And it turns out that as soon as I started getting proper therapy for complex PTSD, all of those systems started improving.
Right.
It's like, why is that? Oh, it's because we're not actually realizing that all of this shit is interconnected. And all of the drugs that you have for IBS, the reason that they only work 40% of the time, and even when they do work, it's only a mild reduction of symptoms. It's because you're not addressing the root cause.
Yeah. Well,
you
look,
know?
so ask any pediatrician, and I'm obviously not one. I don't even work with pediatricians, but we see a lot of pediatric emergencies. We see a lot of kids in the ER, and I can tell you this: they all got tummy aches.
Mm-hmm.
And the tummy ache is usually a sign of they're upset about something going on in the home.
Yep,
So you even
exactly.
know in kids that mental health issues, stressors, environmental stuff, social stuff manifests as GI disturbance. I mean,
Yeah.
yes, 100%. And we're going to
100
start figuring all this stuff out in the next 50 years. It's going to be amazing. I cannot wait.
So to that point, just as a final point on that topic, anytime my wife and I have figured this out, that anytime we get a call from the school nurse saying, you know, your daughter is in here because she threw up at lunch.
Yeah.
They always ask questions about, oh, blah, blah, blah. And our first question was, can you ask her if something happened before lunch?
Who's mad at you? Who talked crap about
Exactly.
you? Who
And
kicked you off
every
the lunch
single
table?
time.
Yes.
Every single time.
Yeah, I know. So if it's true for kids, why isn't it true for us? It is true for us. It is true for us.
Exactly. It is true for us. We're just in complete denial.
Yep. Agree to agree on that one. All right, so we'll go in about 10 more tangents here, but let me keep going here. So then there's a section called the need for psychedelic integration. So basically they're acknowledging that these are major experiences and not everyone's poised or has the capacity to handle the back end integration on their own. I do truly believe there are people in this community that have some qualities about them that let them integrate these experiences pretty successfully on their own. Do I think literally everyone, regardless of that aptitude or lack of that aptitude, do I think that anyone having major psychedelic experiences on any psychedelic, any macro dose, would benefit from formal integration with somebody? I do. I definitely do.
Wholeheartedly.
That's why we're doing this podcast. So anyway, these people agree. It's good because they're the therapists. They're getting this all going. So they go on to say the purpose of this paper is to address the risks and needs associated with psychedelic experiences and outline our attempt to develop comprehensive guidelines on both theoretical and practical aspects of psychedelic integration. Such guidelines may inform the individual practice of various mental health specialists who may encounter and work with clients in need of support with regard to the content and or consequences of psychedelic experience. Great. Yes. Awesome. All right. Let me pull this paper up. I just realized that I've just been reading. Some people might want to follow along. So let me pull this thing up. All right. So where are we at? We are now at...
Actually, while you're doing that,
I
there's
might
a
be
point I'd like to...
Go for it.
There's
Yeah,
something
while
I'd
I'm
like to point
scrolling,
out.
talk.
So I think one of the most important and simultaneously frustrating things about this whole process, and I'm talking about therapy plus psychedelics. I'm not isolating one portion of it or the other. I think that the most frustrating part of it as a patient should be the fact that, so you hear all this talk about integration, and anyone that you talk to, especially any Instagram influencer, will rattle on for 40 minutes about their process of integration and this is important and that's important. But here's the frustrating part is, as a clinician, or reading this as a clinician, one of the most fundamental questions, it has to be, what the hell does integration mean?
Yes.
And the frustrating part is there is no actual definition for it. So the reason I really want to bring that up is more on the, I really hope that folks are looking at and listening to anyone that's talking about this stuff with a lot of suspicion, and with very much a trust but verify attitude. Because the reality is there is no standardized definition for it, and it really is important because you can't talk about improvement if you're not even talking about the same thing, if you're not on the same page
Yes.
from the very beginning. Like,
Correct.
language is very important. And you and I were talking about, like, with Oregon and setting up these pseudo clinical, I don't want to call them dispensaries because they're not, but it's like, yeah, it's fantastic that we've set up, that we've passed these initiatives, that we've gotten these made into laws, but you're relying on folks now to treat folks that legitimately are having challenging experiences and could really use a talented therapist or a talented guide, even at that point.
Right.
And they're not going to get it because people can't get on the same page as to what type of support they're going to offer or need to offer.
You just made me realize that. So, these places, they're legalizing it. These therapy centers are opening up. So these legal therapy centers providing ketamine, psilocybin, what have you, it is all operating while simultaneously, just a freaking month ago, this paper comes out from a bunch of professionals saying we haven't figured any of this out yet.
Mm-hmm.
So we want to do some sort of preliminary trellis-like framework to start building this around. That is, I'm sitting there going, okay, and how much was it?
Yeah, exactly.
I defended it earlier, and I'm sitting back going, okay, but also, you don't know what you're doing yet. You literally don't know what you're doing. That's why if you want to go down to Colombia and have some random dude you've never met do a ceremony, cool. That's as safe as doing it with the person you're going to.
Yeah, truthfully,
it is.
It's
probably more safe, just because they've done it so many times.
Exactly, and when you're looking for a surgical procedure, where do you want to go? The FYI, this is an insider tip for everybody. Where do you want to go? You want to go to the place that does all the research, or you want to go to the place that does all the cases? Right. You go to the place that does all the cases.
Yep.
It's because they have actual hands-on experience with this stuff.
Gosh darn it! Hold on, I have a sneaking suspicion it's overheating.
A loose plug.
But
oh yeah.
All right, man. Never run out of technical difficulties. That's infinite. Fun. Okay. Yes, I always tell people, because people they find out in the ER they're going to need a surgical procedure, and then they start asking me for advice, and I just say the procedure you need is very basic. We've done 1 trillion of them. It's sometimes I say things like, it's the most common medical surgery we do, right? Gallbladders, they have done 1 trillion of them. You don't need to go to the world's best hospital. You just need to find the guy at whatever hospital you're at who does the most gallbladders. That guy's probably going to do a good job.
You want the guy that can do it half awake at 2 a.m. with 0 complications. That's the guy you want.
You want the guy that no matter how junky your gallbladder looks, he doesn't even his heart rate doesn't even go up 2 beats a minute. He's seen it all, doesn't care. Yes. All right. So speaking of, let me pull this back up here. So speaking of definition, they do identify that is like the first issue, right? So
Yeah.
they're talking about they had these roundtable discussions.
And how the process that they go to actually define it, it's literally they went to the 30
somebody else
therapist. Yeah, they went to the 30 therapists on the roundtable and said, "What's your definition? What's your definition?
Yes.
What's your definition?" And then they just said, "Okay, I heard these 8 terms the most often."
Yes.
Like,
the one is, and I agree with this. I almost felt like they never actually said their definition, but the end of the segment of what is psychedelic integration was this quote from this paper where they said, this is their supposed, so my take was they liked this one the best. So right there, a process in which a person revisits and actively engages in making sense of, working through, translating, and processing the content of their psychedelic experience. Through intentional effort and supportive practices, this process allows one to gradually capture and incorporate the emergent lessons and insights into their lives, thus moving toward greater balance and wholeness, both internally and externally. I don't hate that one, but I was mostly perplexed by the fact that they never actually seem to have formed their own definition after getting done saying it's so important to have a definition. But this one's pretty good. I don't hate this one.
Yeah, and to be clear, I am in no way bashing or hating on them for this approach. I'm really more trying to illustrate for everyone listening that this is actually incredibly complex.
Yeah.
It is, and I don't think that 99% of the people currently involved in it actually have thought of all of this stuff, like actually thought it through. What does integration actually mean? It's like, yes, I can do yoga, 3 days a week, and I can journal and meditate, but why am I doing that? What is the purpose? What is the end goal?
Right. Well,
and that's what they're trying to do, and I really commend them for it, because to your point, I don't think that there is a step 1, step 2, step 3.
Right.
It's really for that well-educated and well-qualified therapist to determine what does that process look like for that individual patient.
For them, and for them, how they're going to
Yeah,
practice.
exactly.
Yes.
And for the individual therapist.
Yeah.
Because not everybody's good at everything.
Yes. Also, given I love to step back and look at the forest for the trees. So in this case, it's also important to go, where'd they even get this term, integration therapy? Mm-hmm. They didn't get it from themselves, because they're acknowledging that they haven't even figured out what it is or how to define it yet. So it came from outside their community. It came from our community.
Exactly.
It came from an older community. It came from the shamanistic, the ritualistic, the healer community. It came from an ancestral kind of community, not current Western medicine. That in and of itself is interesting to me, but nowhere in the paper is there ever much acknowledgement specifically of that they're responding to something that has been rediscovered, something that is now being advocated for by some of these old practitioners, by people who, like Rachel Harris, has talked to these old practitioners, by growers who have grown this medicine for decades, right? I've had people on this podcast that have grown for over 30 years. And some of those people learn from people who were growing 20, 30 years back from there. So there's this rich underground history of this, and now this is coming from the underground, and you got Western medicine going, yeah, we got to figure out what integration therapy is, because this community keeps talking about it. And they want to do it, and they're coming to us for the answers, and we don't have them. So I love the fact it is also an interesting, sticky little scenario. The fact that that somebody outside of Western psychiatry has invented a thing that they're now trying to build a model around.
Mm-hmm.
I love that. I love that because that just shows you that our existence is valid. The community we come from is valid. It is important. It is significant. And any growth in any mainstream activity, if it's going to succeed, it needs to come from and have origins and roots in what we do. That's what I think is important to say about that.
Agreed.
All right. So they get into in the section on, is it solely in the substance? They start talking about set and setting. I again love this.
Yeah.
They're talking about terms that did not come from them. That just makes me happy. They're realizing, yes, and they cite numerous articles. You guys can look into it if you're very interested in this, but they're acknowledging the set and setting model. They say the influence, the side of the substance, set and setting should not be underestimated, as they clearly play a role in both the quality and potential risk of psychedelic use. I love that. Every time somebody tells me I tried LSD, I didn't like it, I had some really bad trips, I say, tell me about who you were back then.
Exactly.
When you had that bad trip. Were you a bad person? Were you burying some shit? Where were you at? Where you were at was probably reflected back to you in the trip. But you didn't have a shaman, you didn't have a spirit guide, you didn't have a clinical psychologist who was trained, or a psychiatrist, clinical psychologist or psychiatrist who was trained to help you integrate that bad trip. That bad trip might have been the trip you needed. It was just too much for you. And you labeled it a bad trip.
Exactly. Yeah. And also, where were you physically? Because, the first time you had LSD was at a concert. Probably not the best place to have your perception of the physical world altered. Yes. Right. And also the taking that, but kind of flipping it 180. What did we do in the 50s and 60s at a governmental level? We literally strapped people in with leather belts onto tables in whitewashed rooms, and then gave them high doses of psychedelics, of LSD.
Surprise!
And wow, they all had terrible experiences.
They all hated it. Yes. Go figure. Yeah. I talked to the spirit pharmacists about this. I've talked to a lot of people about this idea that this is such a novel drug class, because this drug works differently based on what I thought about that day, what I wanted this drug to do to me. It would be like if I could have a blood pressure pill where I could go, I want my blood pressure to go down by 10 points. Goes down by 10 points. Tomorrow, my blood pressure's up. I want it to go down by 40 points. And I can actually just think it, and it has a different effect based on those thoughts. I'm really oversimplifying it, but this is a drug that affects all the neurochemistries up there, all the neural pathways. What I think about matters. So I'm glad that these people are acknowledging the set and setting plays a big role. They actually make this, get ready guys, this is a bunch of PhDs. This is the complex. I'm teasing. I'm giving these guys a hard time. Right?
We're not very creative. We're not known for
this stuff cracks me up. That you didn't even have to do this chart. I understood what you meant, but this is true. I guess what is important about it is it's showing that the set, they're really placing the set and setting equally in size to the drug itself. So maybe that is significant. Maybe that's not accurate. Who knows? But they are trying to say these are not to be overlooked. And then I also appreciate, which I think you touched on earlier, they're acknowledging that sometimes this doesn't go well.
Yeah,
And
absolutely.
maybe we should be looking at set and setting as factors that
Hmm.
participate in that outcome. So they said further, according to existing research, factors like high personality trait of neuroticism, personal family history of psychosis, borderline personality disorders, mania, or related psychiatric conditions, inappropriate context. I want to know exactly what that might be a professional term I'm not familiar with. Being an unexperienced user of a particular substance, as well as lack of or insufficient post-experience integration. These are the most commonly associated causes of these
Yeah.
adverse reactions. I appreciate
That
that they're talking about this because I feel this is lacking in our community. I have people who are,
FYI,
yeah.
that context that they're referring to, it's what I alluded to with like, hey, I took this in the middle of a concert,
Oh,
and
okay.
also,
Inappropriate content. Okay.
but also like, hey, I just had a family member die, versus I just got
R-
an A on a paper. Like
Right.
very, very different mental states of mind.
Yes.
So that
Yes.
also goes into the context.
Okay, that makes sense. But this is important. I have people who come to me and go, "Hey, I'm on a bunch of psych meds. How many mushrooms do I need
Yeah.
to eat?" And I say, "Man, I if you can get off all of them for an appropriate amount of time to where I know they're not in your body, then I can maybe answer that question. But now you've put yourself at risk of, a psychotic episode in and of itself. There are really people that maybe are precluded from this activity as is right now. I would
Yeah,
never tell a
absolutely.
schizophrenic to go have a trip. Most current research suggests the schizophrenic's brain is operating like our brains do when they are tripping.
Hmm.
So I'm not going to tell you to go make that worse. Yeah. All right. So where are we here?
What if their tripping is what our reality is? They're like, whoa.
Whoa, dude. What if we're really all supposed to be No, we're not supposed to be, but okay. Um, they are. I did read a couple articles not too long ago that were suggesting that there was the papers basically at the end said there's a lot of opportunity here. The more we know about the psychedelic experience, the more potentially we will understand about schizophrenia.
Yeah.
If we know the chemical mediators involved in all the little processes that are going on in the brain, it could theoretically help us come up with novel therapies for schizophrenia. Hey, cool, great. As of right now, there's no fix for that. It's just how numbed out can we get them so that they have essentially no moods and are just almost
It's
zombie-like.
purely symptomatic control. It's nothing
Yes.
is ever actually addressing the schizophrenia itself.
Yes.
It's can we medicate this person to not necessarily function at in society at large, but to not disrupt society at
Yes.
large. I think
Yes.
that's the more realistic goal, or
Right. I
not
agree.
necessarily goal, but the reality of treatment.
So I'm gonna just post this up just because I thought this was an interesting counterpoint. Um, JC Cat says it's a difficult situation. Many people who need this medicine the most are high risk, or so we're to
Yeah.
believe. You're right, which is why we gotta roll up the sleeves and get this all figured out. Which is why it's so exciting that this paper's being written because it's suggesting that this profession, this body of professionals, are starting to be willing to do this work. So amen 100%.
Absolutely.
So the next section, this was the section that I thought would be very interesting. And guys, if you guys in the comments want to chime in on this one, I'd love to hear what you guys think. The question, the headline is, should therapists have their own psychedelic experiences? So let me scroll down here just so I can get it all on the screen. So it says here, the issue of whether one's firsthand experience with the effects of psychedelics among those working with psychedelic experiences that is therapists, is necessary or not is a subject of ongoing debate in the field. We believe that firsthand experiences with psychedelic substances are an important consideration also among mental health specialists offering psychedelic integration and not just PAT. Such experiences can provide personal insight into the nature of psychedelic effects, which contribute to understanding clients' experiences and related difficulties in the way that reading guidelines such as these or undergoing clinical training alone cannot provide. Okay, let's stop there and talk about that idea. I can tell you that I see every single day that any personal medical history that a provider has directly and positively informs their clinical daily practice.
Yes.
I can't
Yes.
emphasize that. I'm like getting emotional. It's so, if you work in this field, the difference between watching somebody apathetically put in a migraine cocktail for somebody with a migraine 30 minutes after they show up versus the attending that literally runs in the room within seconds of the person being put in the exam room and talks, but as they're talking, puts in the order for the migraine cocktail and then looks at you and it's like, go get the migraine cocktail. It's the difference is compassion, experience, and understanding versus just rote clinical training.
Yeah.
And
100%.
people feel that so hardcore. The school I went to for nursing, I was pretty hardcore taught around what's called the Roy adaptation model. It was a very significant nursing model. The whole idea is the holistic approach to the patient.
Yeah.
And clearly my camera saga continues. Hold on. We'll just be doing this all night, guys. It's fine.
Well, to that point, I yes, I wholeheartedly agree that it should be a prerequisite for. I was just saying, I wholeheartedly agree that I think it should be a prerequisite for any clinician that's working with these patients. Because I mean, yes,
Ideally.
everything aside that you just said, which I, from a personal standpoint, I can tell you he's 100% accurate. It, to me, it would seem as an impossible task as describing what fireworks look like or what the Beatles sound like to Helen Keller.
Yeah.
Like,
And the
it's
difference
just
is
you have to experience it to go,
yes.
oh,
Right. But now, of course, it would be great, right? In so many other specialties, you can't do this. You know, maybe you're lucky and your orthopedic surgeon has, gotten a trimal fracture, or maybe they've had some sort of orthopedic injury requiring surgery. So they get a bit of perspective. But if they haven't, and most of them are really fit, ex-athletes who take good care of themselves and they've never really had a major injury to speak of.
oh yeah,
My guess would be 90% have never had an orthopedic procedure. So they're just following protocols and data from good research projects. Yeah, you should be pain free in 10 days. So I'll write you for 10 days. And then good luck getting a hold of my office for a refill. Oh, you have a complication, just go to the ER, right? There's not a lot of sympathy there. I had a spiral fracture in my distal tibia. I had to have a rod placed. I know what it feels like to have a hole drilled through the length of your tibia. A rod slammed into it. The recovery on that is pretty rough. Every time somebody comes in with any bone injury, anytime somebody comes in with osteomyelitis, which is a bone infection, anytime we have to do an IO, IV access on somebody conscious, which putting it in is not the problem, but the minute you go to flush it, these people like literally leap out of bed right?
Yeah, they hit the ceiling.
I have sympathy for them because I have felt it, but I can't have every clinical situation experience, right? I can't have every illness that ever existed, but these people can. These people can have their own experience because this is a positive therapeutic intervention and it directly informs their clinical practice. So I'm with you. I personally believe, for me, if I got the choice between a clinician who's never had a psychedelic experience and someone who has, that's a no-brainer.
100% of the time.
No-brainer.
Yeah.
No-brainer. So in that way, and I doubt if you polled 1,000 people, anybody would say any different. So it sort of seems like the demand would be there. The expectation of being a successful clinician in this way would involve having that experience.
So I'll give you a corollary to further illustrate it. It's the same type. It's the same reason why representation in medicine matters, because if you have a physician of the same cultural or ethnic background as your patient, and I'm again speaking from experience, there are phrases that don't translate into English. There are ways that we grow up. There are similar traumas that we all experience because of our cultural backgrounds, that it not only strengthens that rapport and strengthens the bond that the patient and the clinician can form, but it also very much helps on the clinical side, where I, as the clinician, know when the person is being hyperbolic about an account that they're relaying versus I can tell because of their body language,
Right.
or because of the tone of the way that they say certain words, that they're really distressed or like actively dissociating. And again, I'm speaking from personal experience, being with a therapist that, you know, white bread middle America has never dealt with anything. And I know you can't tell, but my name gives it away. I'm the son of an immigrant, and my current therapist, exact same background as me. And we can be talking in circles about something, and I can just look at her and go, well, you know.
Right. Oh yeah.
It's, if nothing else, it sets the person at ease that much more, to where the therapy can be a lot more effective, both on the psychedelic side with set and setting, but also with the integration side and facilitating vulnerability to where the person can go deep enough in that experience.
Oh yeah.
To really flesh out those repressed emotions.
That rapport, I mean, I have in almost every job, maybe not in the ICU because you're kind of you're in your little lonely island when you're there, but any of the other clinical settings I've worked in, I'm frequently the person that calls in when somebody else can't get somebody to participate in their care.
The difficult patient.
So I come in and magically they want to, participate in their care. And sometimes I've had people go, oh, how do you do that? Or, oh, why do they listen to you? Sometimes people go, oh, it's just because you're a guy. A lot of the ladies like to say it's just because I'm a guy. And I'm like, no, I'm telling you right now, I can literally look at that patient and just how I'm looking at them, the tone I'm using when I'm talking to them, that I'm cracking a joke, that I'm asking them a question, that I'm touching their arm for 1 second, or whatever little thing I'm doing is communicating to them that this is not a job in that moment, that I care about them.
You see the person.
That I see them.
It's not the number.
Exactly. They're not the chest pain in room 2.
Exactly.
Yes.
Exactly. It's Dorothy from wherever.
All it takes. Yes, that's literally all it takes.
Yeah, there's no secret sauce or secret formula. Well,
but
what'd
you
you
can't
do?
teach that.
I fucking listened.
You
That's all
can't
I did.
teach it, though, is the problem. They like to think you can take a 30-minute online
Yeah.
thing and learn it, but it doesn't quite work that way. All right, so we're definitely on the same page with that. They actually bring up, where is it here? They say this view is based on other authors' recommendations for psychedelic therapists to have their own experiences with non-ordinary states of consciousness, be it with psychedelic compounds or with a variety of non-pharmacological methods such as holotropic breathwork. Then in one paragraph, they say, however, we do not assume that personal use of psychedelics is necessary to provide support with regard to the content and or consequences of a client's psychedelic experience. I sort of didn't know if I understood what that meant. You can give your interpretation. I kind of thought it just meant like on a more fundamental level, on a more surface level, they could respond to things they were told about the experience. They could talk about ramifications of certain things that were revealed or uncovered based on the experiences they had. I didn't quite know what to make about that sentence, to be honest. It seemed like maybe it was written by committee and it lost its actual meaning at some point. I don't know.
They're basically saying, look, that we, at least the way I took it, it's, look, we recognize that the ideal scenario would be to have a clinician be intimately familiar with this type of experience. However, we also recognize that, and also we have to legally put in, you might not legally be able to have that experience, so you can maybe get an approximation of that using techniques like holotropic breathwork. And to that extent, for folks that have ever read How to Change Your Mind by Michael Pollan, he talks about a specific experience that he had when he was, the day before he was going to take LSD, like have an LSD ceremony. He was offered MDMA, but because he had an arrhythmia, he didn't want to do that. So the next best alternative was holotropic breathwork.
Right.
And essentially, if you really want to get into the physiology of it, what you're doing with holotropic breathwork is you're decreasing the bicarb content of your blood. You're lowering the pH. I'm sorry, you're increasing the pH, making the blood more basic, and that can induce psychedelic like, I don't want to say hallucinations, but visuals and abstract thinking. So it's like it's not perfect, but it's an approximation. More than you're going to get with a beer.
Yeah, maybe lawyers. Somebody just said, Raymond Stout just said, well, yeah, it was such a good time here. They got to go sleep. But then he said, oh, wait, sorry, I just pulled up the wrong one. Hold on. All right, take care, Raymond. Sorry, where is it here? Here we go. Michael Mama said, I think they're backpedaling in the next paragraph, citing illegality. Yeah. For sure, some lawyers had some involvement in this.
There's a lot of double speak throughout this because they you can tell they're in an academic vein, being like yes. Oh, by the way, most of this is not applicable to where it's illegal. So.
Yeah, that was my favorite, where they're like, well, one reason not to do it is it's illegal. Mm-hmm. Okay, we know. And yet, look what we're doing. Okay, so let me keep going here. Oh, actually, before we go, I think there was a couple statements I wanted to pull up.
Yeah, here. I have it. Further, Nielsen and Gus have pointed out that a therapist's firsthand experience with psychedelics, while common in the history of medical research on psychedelics, is largely omitted, undocumented, and understudied, which indicates the need for reliable investigations. Why is it omitted, undocumented, and understudied? Because we as physicians, the reality is we are subject to a lot of coercion and frankly extortion when it comes to maintaining our licenses. So there's a lot of things that we can be hugely proactive or, advocates for, but the moment, like, I'll acknowledge I'm taking a very big risk, talking about this stuff
Sure.
publicly.
Yeah.
But it's, for me, the or the benefits outweigh the risks.
So Myco Mamas have been saying for a long time, if one guy's doing something, quote, illegal, then you just go after that guy. If everybody's doing it, if there's a massive mob of people, it gets harder to decide who you go after. Doesn't mean they don't go after somebody, but I'm inclined to like this line of thinking of we should continue to advocate for our rights to use entheogenic medicines, to seek out help and medicines that are not available from Western medicine. I mean, this is what I'm absolutely doing this for. So I want more people doing this. I definitely think that it gets hard to ignore the more people who are doing it.
I wholeheartedly agree with that statement, but again, the reality is yes. So let's go back to the statement. If a lot of people are doing it, it becomes difficult to pick which one to single out. But the reality is they don't have to strategically pick someone, strategically single someone out, because what they lack in strategic assignment, they will more than make up in punitive punishment.
Sure.
They're going, because the law enforcement has a history of being very effective at sending a message using punishment.
Yes.
And they say, and if you really want to pursue it, ask any career prosecutor that has worked at the federal level. How do you, why are most federal prosecutors, why do they have insane conviction rates? Because most of them plead out, because federal minimums, dictate that you got to serve 85% of that sentence.
Right.
Like, yeah, sure, we'll give you a chance, but if you mess it up, we're going to nail you to the wall and show everybody.
Right.
That's the reality.
Yep. And I don't know. I think it's all how you frame it, right? If this is why I brought up the kid in Connecticut, right? So I'm not the same. Me growing some tubs in my basement for myself and a couple family members, that is a different decision I'm making than to have a 1,000 bag grow operation. I'm obviously not doing that. I don't think he was giving away the fruit, right? That's being done to sell it. A lot of people do a lot of illegal things to make money. Unfortunately, in our country, some people are born into privilege and born with opportunity, and some people are not, and those people make other decisions. But it's a different decision to be made, right? I definitely think law enforcement, the minute you want to start selling fruit, you're making a different decision than wanting to grow medicine for yourself or advocate that people should want to grow their own medicine. It's a different decision is my take. But sure, if somebody decided they want to make an example out of me, I'm about as easy a target as it gets. So we'll see, guys. We'll see what happens. If the MycoGeeky podcast magically disappears, you'll know why. But I'm not losing sleep over that one. All right, diatribe. Here we go. Back in it. So then they get into how psychedelics work. We covered that a little bit before, but they got to get into that because a lot of these clinicians are actual doctors. They want to know these things. Even the non-doctors are going to want to know these things. But I like this section. They said the psychological correlates of these changes are known as the afterglow effect, according to this paper. This may last about 6 to 8 weeks after the consumption of psychedelics and is usually characterized by slightly elevated mood, optimism, higher openness, as well as weakened ego defense mechanisms, resulting in higher vulnerability. When I had the Townsends on, they talked about this. When he had his first experience, he came home and his wife was like, "Whoa, who are you? I like this guy. This guy's in a good mood. He's this, he's that, he's the other thing." And it's fascinating because I asked her, I asked Wendy, when do you think that wore away, or kind of went away? And I think she said a couple months. So that correlates pretty strongly with that. Now, here's the important point. Here's what's important to bring up. If you just have the trip experience with no integration, no thought, you will enjoy some benefits afterwards, 6 to 8 weeks, improved mood, this kind of thing, more openness to changing behaviors, thought processes, whatever.
Assuming it wasn't a challenging trip.
Yes, assuming it was a positive trip, yes. But then that afterglow effect goes away. So so the real opportunity is that you're in this great state for maybe a couple months afterwards, if it was a good trip. How do you maximize that? How do you capitalize on that, to use an American term?
That's when the steel is hot and malleable.
Yes.
Is in that, 4 to 12 week period. That's why integration is so important. That's why building this framework is so important. Because yes, the psychedelic experience and the actual chemicals are very important, but they're only a tool. Like, you're not going to get any lasting benefits. The person is not going to do themselves any favors unless and until they do that work afterwards. That's really the benefit of psychedelics, at least in this setting.
It to use the blacksmithing metaphor, right? You could take a cold piece of steel and hammer it for a very, very long time cold, and it will eventually give and change shape. You heat it up because it softens it, like you said, it makes it more malleable, and you can do more work more quickly. This is the real opportunity. So I think this is the win. Like, if I was a psychiatrist or a psychologist working on this paper, this would be the real, like, I would want to put this in bold. This would be the big deal.
Yeah.
It's, you have an opportunity. You have a window. This is the important part. So in defining integration therapy, I would, in my definition, say, we know clinically there is this period of time following a trip, some sort of psychedelic experience, where we as clinicians have an opportunity. We can get more done more quickly, strike when the iron's hot, to use the metaphor. And that was absolutely kind of not in the definition at all. But for me, that's the most exciting part. I'm sitting here reading all this.
Agreed.
This is what's important. This is why I just had a couple people comment and say, "Oh yeah, it's about right. I dose about every couple months or about every 10 weeks or whatever." Okay, cool. Yes, great. And you can keep doing that. That's fine. If there's no integration there, then you're using it for the slightly elevated mood, the optimism, the higher openness, all these things that they're identifying as very positive net effects, but temporary.
It's essentially symptomatic control.
Symptom control. The real work, the important work, and maybe you can do a bit of this on your own through repeated tripping, but the real work, the real opportunity is that you could be making, and you might need to have intermittent macro doses in order to get through a bunch of stuff, depending upon what your history is. But if you're not also going in this period of time afterwards, is the real window for me. I could do some real work with my therapist. I could, this is what it's going to be all about in the future, this is the integration. It's really integrating the therapist into your state after this macro dose where you can maybe get some magic to happen. Or you can not do that and do whatever you want to do. But that's the point here. I think this is the exciting opportunity. You could take a drug and potentially condense 8 years of therapy in 2 months. You really could. You could. Ask your therapist. If you go see a therapist, how long does it take for people to work through some of their shit? They're not going to say a couple months, I can tell you that. They probably have clients they've worked with for 5 to 10 years.
Well, and it's one of the stated it's one of the stated successes or reasons for success with combat veterans and PTSD and combat veterans PTSD and MDMA therapy. Right. Why does it work? It puts the person in the mental and maybe more importantly biochemical state of mind where you don't have to go through the 400 hours of talk therapy to develop that level of rapport, come back to rapport, where you can actually say, this is my deepest fear. You know, this is why I have nightmares.
Right.
That's really what it comes down to. It's
that's exactly right. Especially for men. Sometimes they go into therapy. I go couples therapy sometimes. And if we get a new couples therapist,
that wall's up.
And they meet me, right? My wall is up, but also my wall's probably not as up as the average man. I'm pretty willing to talk about stuff. And sometimes I can see the looks on their face where they're like, oh, this guy's actually talking. And, oh, okay, yeah, you can see this look where they're like, holy shit, the guy's saying something. He's not just sitting there stewing in his own juices the entire therapy session. Wow. But then they don't know what the fuck to do with that. But anyway, that's neither here nor there. But yeah, this is right. And I've had I tend to have my walls up more in individual therapy, I think. But yeah, some MDMA. I'm just in that part of my brain that's worried about that person, whether I can trust that person. That part of my brain isn't doing its thing. The part that wants to just feel and feel and feel and talk about feelings. And that's the part that's right. That's what we love about MDMA. So, dude, that's it. I like those 2 low points that we just hit on. Yeah. All right. Those are important. They go on to say here, hold on, I'm past that one. Let me get to where we're actually at. Pull this back off, this back on.
I keep looking at my picture on the screen and I'm fighting these intrusive thoughts that I want to try to do the Ron DeSantis smile.
Oh. Oh my God. Politics. Somebody messaged me today saying, hey, you should do this podcast topic. And it delved into the political. And I was like, I would love to talk to you about all these things. I do not want to talk politics. No.
It's
I don't
so
think it's
polarizing.
I don't think it's worth even talking about anymore, to be honest. I'm trying to keep my politics local to me and the things that matter to me and the fights I need to fight. This is it for me. This is as political as I get. Okay, so trust the inner healer or be directive. This section, we don't have to get into this. Go.
Well, I actually thought this was so just to like briefly recap what the trust the inner healer or be directive portion was saying is it's how, number one, it's recognizing that the brain has, like the rest of your body, an innate ability to at least start repairing itself.
Right.
but I think that there are some very big, potentially very big issues with, and they kind of acknowledge it with the trust the inner healer portion of it. Having effective therapy, but not really having effective in inner healer really depends on the person already having insight into their issues.
Right.
I really don't think that anyone that has not had any therapy, like meaningful therapy, will be able to really do this on their own, because the ego and ego defenses get in the way to the point that you can't recognize certain issues, like you're blind to those issues.
Right.
And we talk about these things like from a psychiatric standpoint. We make assessments on the person's capacity to understand their own situation, their own issues. Do they have the wherewithal to understand why they're in trouble? Why are you involuntarily committed to a psychiatric hospital? Some folks genuinely don't have that ability to turn
Right.
the eye inward, and that's really where the inner healer paradigm falls apart, because you can't treat a tumor with a tumor. you know
Right.
it's you need an objective third party a lot of times to be able to say, yeah, I agree with you griping about this thing over here, but have you noticed it has to do with all this stuff over here? It's being
Right.
able to see the forest through the trees. And I don't think that humans in general are reliably able to do that.
I agree. Not only the fact that this is an abstract metaphor, this is a concept. I can show you your brainstem. I can literally prove what it does, right? You know
Hmm.
exactly, you know all the intricacies of the brainstem. You know what each part does. You know what the hippocampus does. You know what every little part of our brain does. That frontal lobe does all sorts of stuff. We don't exactly know what that's always doing. Um, but like to say, well, right, our body heals itself. Okay, but I can, right, if you cut yourself, I can tell you specifically what your body is doing. It generates
Hmm.
connective tissue. It brings an inflammatory process to that area to flush out, byproducts. And we can explain all of that. And there are specific scientifically known mechanisms that allow all that stuff to happen. But to then say, well, because if you cut yourself, it heals. Or, the way sometimes the body will compensate for acidotic or alkalinic states,
Yeah.
right? There are some of these known facts. Just because you can take this concept, I don't know if you get to then go, well, but then the mind is just going to do the same thing.
Yeah.
Feel it's
Well,
a
even
pretty big leap.
yeah, no, I agree. And to you guys aren't in our Instagram DMs, but we frequently send each other uh, videos of
High,
injuries that go,
high level.
whoo.
Yeah. Yeah.
So where I'm going with this is, he and I frequently send each other videos of, a guy that has a distal humerus fracture
That never
that's,
healed.
completely broken above the elbow. And yes, technically the body has healed it in a sense that his arm is still attached and his fingers still work, but the guy's able to swing his arm around like a rope. Like,
Yeah.
yeah, I wouldn't really call that fixed. I would call
Right.
that stabilized.
Right.
So there's it's a bell curve. You have
Right.
extreme, or you have outliers either end of the extreme.
Yeah.
To the comment previously, unfortunately, I think most of the people that would legitimately need this therapy, a large part of them are in one extreme.
Right.
So we can't really expect the person that is having a lot of these mental crises to have the best insight,
No.
right?
Or I mean, neither one of us are psychiatrists, but I think everybody knows this, right? We know about repressing very serious traumas.
Yeah.
People repress traumas. It is a protective mechanism of the brain to go, that was too much. I'm just going to forget about that. Right? That's a known mechanism. Now most of the stuff I've been reading about narcissistic behavior is there's actually some compassion around it, because it's usually a behavior trait that's formed around a lot of abuse and trauma as well. So as I'm hearing about this inner healer concept, I'm thinking I can think of so many maladaptive ways that turn into psychological problems for adults that are based on this inner healer doing its best to try to protect the person, the ego, whatever you want to call it. So obviously that inner healer isn't always doing the best job for us.
Yeah.
So I'm not even necessary, right? This is why when I say things like, I do know people that I do believe are doing a pretty good job of integrating their own experiences for themselves. 1000%. Do I know that for a fact? No, I'm just, that's my intuition based on what I know about these people, how they talk about these things, how they talk about their trip, how they talk about their understanding of it, all this kind of stuff. For sure, 100%. I don't know if any of us should be utterly trusted in and of ourselves to do all that work for us. There's a huge benefit to bouncing right? If you want to just make it in business terms, let me just bounce that idea off somebody. I think I got a good idea, right? I'm a rock star. I'm a musician. I've got a #1 album right now. And I think I got this great new song idea. And then you play it for Timberland and he's like, nope, not feeling that. Well, okay.
Well,
Sometimes you gotta get perspective from somewhere outside yourself. Yes.
It's the same reason that we don't treat family members.
Yes.
It's, you can be as objective as you want, but at a certain point, you will involuntarily invoke ego defenses because you don't want to tell mom something that's going to upset her, or you don't want to tell grandma, hey, I might kill you doing this surgery, or God, you might have to make a really difficult decision. So
100%.
these things do matter.
Now, we were trained on, although fairly lightly, but there was some talk at various points in nursing school about transference, and that especially for a nurse, because you're more intimately involved in, executing an intervention, you're around the patient quite a bit, that you really had to watch out for transference, which is this idea that, right, let's say I get a woman in for chest pain. She ends up having a heart attack, and she reminds me of my mother, right? It's the idea that I will transfer my feelings about my mother onto this patient, and it might inhibit my ability to take care of her.
Absolutely.
I definitely think that that stuff can be worth exploring, because say I'm a therapist, I've had my own trip experiences, and then I'm trip sitting for somebody, or I'm involved in that journey, or maybe just I'm doing the integration portion. I could get triggered, right? This is I'm playing devil's advocate right here, but I'm thinking out loud, right? The same way that we're sitting there going, oh yeah, definitely, I want my therapist to have experience with psychedelics,
Mm-hmm.
it's also possible that their experiences could then trigger things
Yes.
during my therapy. That's also worth exploring for these professionals, and worth, if you're looking for somebody, you should be asking questions about this. How were your trips?
So yes, I wholeheartedly agree. The thing that I will say about it is these mental health professionals, and really just speaking about psychotherapists and psychiatrists that specialize in talk therapy. They're the only group of healthcare professionals that get specific training in how to mitigate that, or mitigate
Right.
for that, I should say.
I see.
Because you deal with, you're a PTSD specialist, you are absolutely going to have things that trigger you. If not the content that's being discussed, then for sure the reactions that you are intentionally eliciting. If you are a person that has had substantial psychological pain, you don't need to hear why a person is in pain. You can look at them, and a part of you is going to mirror that. That's what mirror neurons in part do.
Right.
So yeah, I think that absolutely is a risk. It's a risk with any healthcare professional. In this setting, I think it probably would be a good thing to either have additional training in that, or at least recognize the fact that, hey, we might not be able to control for this, but let's put in some guardrails where we could say, hey, if the session is approaching XYZ, maybe it's time to either prematurely stop if it's safe to do so, or bring in another provider to maybe take over, something like that.
Right.
That's,
I like that.
it's not perfect, but I don't think that there is such a thing in there is no perfect solution in an imperfect world.
Right. I don't know about you. I have had, I think my best therapy experiences are with people who I have a gut instinct on, that had very trauma-free childhoods, are very well adjusted, had really healthy behaviors modeled for them by their parents. And while a sliver of me hates them for that, also, I do better in that therapeutic setting than if I sense somebody has problems or gets triggered by me, things like that.
It's funny you say that, because now that I'm thinking about it, I think I'm the opposite.
Oh,
I
yeah,
it's almost like I can't take them seriously.
right.
Eh,
Sometimes they oversimplify, or they go, yeah, you just do this. And it's like, but you would have absolutely no idea. So yeah, there's a part of me, but I think overall, there's a part of my brain that says, but you, even though you resent this person for how healthy they are, you want to be like them, right? Like, you want that mental
yeah,
health, don't you? And I
yeah.
try to listen to that voice more.
So like an actual example that happened to me, and this is really why, or this is the example that I was thinking of when I talked about um, the cultural and ethnic bonds that can be
Right.
formed just instantaneously, just by recognition of it. I was having a conversation with an old therapist, and I made a comment about issues with money growing up, and like, we didn't have XYZ growing up, like common things that kids around us where we grew up had. And the response I got was essentially like, oh, why didn't you have it? Did you guys like run out of it, or you couldn't go to the store? I was like, no, because it was either get that thing, which we saw as a luxury, or eat
Right.
that week.
Right.
Like, what the fuck?
Yeah,
So like,
I never had those people say that. I knew people were more affluent or whatever. I never had him directly make it. That kind of a comment would trigger me as well. Yeah.
Yeah. So yeah, there's again outliers in the extremes. I think, for the most part, you want in 87% of all situations, you want that well-adjusted therapist that can, you know, maintain a steady, calm, almost flat affect.
Right.
But then, for those times where you're in crisis, you might want the person that knows that, you don't actually want to kill yourself when you make a joke.
Right.
Especially
Yes.
military veteran. For
Right.
better or worse, we like to joke about, oh man, I wish, I take a 6-foot rope and a short drop.
Right.
And
Yes.
if you're not with the right person, they'll be like, oh my God, I need to
Oh yeah.
really look out for this person, instead of be like, dude, I was kidding. Come on, man.
Right. Yes.
So I know
Yep.
I'm gonna get some weird looks.
Some people don't get that, or some people are so, man, I'll tell you what, it's changing these days too, and depending upon the practice you go to, some of these bigger outfits, it seems like there's like a clinical umbrella company that the therapists work underneath. My guess is it simplifies the business of it for them or whatever, and they give them a cut. It's like whatever.
Yeah, man.
But
Private equity buying everything up.
yeah, for sure. But the tone is very different. There's like,
Yeah,
you
because
can tell
they're
there's another
answerable to
layer.
somebody else.
Correct. Yes.
Yeah.
It's unfortunate. But all this is right. This is just, we're just two random dudes. We do work in healthcare, but right, we're just going through this and finding all these little things that are not being addressed, that no one's talking about. This just shows how important this stuff is. But I do truly believe, this is why I started the integration series. That's why I'm trying to bring more people on, even though, the numbers, if I got Dave Wombat on, the numbers are really high. If I got Nikki Myco on, the numbers are really high. If we're sitting here talking about integration therapy, the numbers go down. It's hard work. It is work.
Yeah,
It is
absolutely.
it's not as fun as the trip usually, right? This is the real work. Now you got to face
Yeah.
your problems. Now you got to work through some stuff. You got to feel some feelings. Not everybody's ready to do that, but there are people who are. I'm here to keep talking about this stuff. I truly believe this is where it's at. Can teach anybody to grow mushrooms. Can we provide them the information that will help them integrate their experiences? That's kind of what I'm trying to do a little bit more of. So
Hey, I'll be right back. I have to restart Chrome. My video's
sure.
been frozen for like the last 10 minutes.
Okay,
I'll be
go
right
for
back.
it. While you're doing that, I'll just graze through some more of the stuff here. All right, guys. All right, so we're going to skip. There's a section here on is psychedelic integration legal when psychedelics are not? We don't need to get into that one. Psychedelic preparation. They get into screening practices. This is definitely important. I mean, my initial gut instinct is, if anybody's showing up wanting to, right, this is now talking about pre-trip experience, having some sort of therapy around it before it happens. I kind of feel like this one shouldn't have to be too complex, but it's saying here, screening for pre-existing psychiatric disorders, other contraindicators, etc. So that's sort of, feel like that's not going to be super controversial stuff, that they should be able to figure that out pretty well. And then they have this practical guidelines section. Oh, here we got Rick back. Okay.
I'm back. I'm not
There we
frozen
go.
anymore.
Video. Look, see, you felt jealous. You're like, Geeky can't have all the camera problems tonight. I got to have something. All right. So I was just getting into practical guidelines. There was, let me find out, where is this here? Okay. So they start creating these models, right? The simple 2-stage model of the course of psychedelic integration practice. We don't get into this too much, but if there's anybody that's actually interested, I have talked to people who have said, I haven't told my therapist yet. I've never told a therapist. Just not comfortable doing that yet. But I also don't live in a cool state. I don't live in a state where maybe the culture is such. If I lived in Washington, California, totally would have talked about this already.
Mm-hmm.
So I think it depends upon where you live. Everybody's got to assess the situation differently. This will, of course, evolve as time goes on. But anyway, they're setting up models for what this integration practice might look like. And of course, I guess preparation is a square box. That makes sense, right? It's just the square box before the trip through the cosmos, then the psychedelic experience, and then you have this early and late stage integration and more psychotherapy. Again, these diagrams kind of crack me up, but it's okay. They're just getting started. Nobody's got their PhD in this yet, so it's right. Wait for a few PhDs around this, and you'll get a fancy diagram.
Honestly, the diagrams just remind me of, or make me think that they didn't think the paper was going to get accepted, and then it did. And they're like, "Oh shit, we gotta do it."
Oh crap, we need some diagrams. Yes.
We referred to figure 8, but there is no figure 8.
That wouldn't surprise me in the least. Well, so we're at a 2-hour point. Instead of getting into this, which is actually probably slightly more aimed at the actual clinicians, though given where we're at, I don't think anybody interested in this, wouldn't benefit from reading through it for sure, because they go through different models and approaches to this. So I do think it's probably worth looking at. The truth is, I think my take on it at this point is we can play as much a role in how this evolves and develops based on, right? Like at some point, I probably should talk to a therapist about this instead of not talking about it. And now a paper like this is going to give me a lot more to chew on, a lot more to think about how to approach them with this. If every one of us in this community who has a therapist decided to talk to their therapist about this, how is that going to elevate and accelerate this growth process within the mental health community? It will, right? So maybe we'll get into this in some upcoming episodes again. Definitely thank you, Dr. Rick, for showing up and chit-chatting a little bit here about this. If anybody has some last-minute comments or last-minute questions, hit us up here. Speak now or hold your peace until next time. Here's a good one from my buddy Bruce. My therapist was totally supportive and actually got into researching psychedelics after talking to me about it. Awesome. Encouraging. Maybe I need to just stop thinking I can't do it and just do it.
That's a good therapist, honestly. Like just the fact that they were willing to take something that you clearly take seriously and give it more than a surface level thought. That's actually a really good therapist.
Yes, I'm probably not giving him enough credit. That is true. And you never know. I think what my situation is, if you have built this therapeutic relationship with them, and then you go, okay, so there's this thing that I've been doing for 2 years that I didn't tell you about. I think I'm afraid like it'll have some sort of negative impact on the therapeutic relationship. Like it's like a betrayal or something. It's probably super dumb to think that, but
no, I actually don't think it is, and it really boils down to how well do you think you know the therapist? Because again, I think the sign of a good therapist is someone that is willing to look past the whole you got better by however much from something that I didn't do.
Right.
And instead of being like, well, you did something without me, and instead
Right.
take it the other way of, holy shit, like, if this actually made my patient feel better, and I know I've been working with them through XYZ things, number one, I'm just happy that the patient got better,
Right.
and B, maybe look into it, and not even, maybe not for putting it as part of your practice, but then just being more familiar with,
Right.
hey, I can show my patient I actually do give a shit,
Right.
and that's just another check marks in that rapport box.
All right, stay tuned, guys. We'll see how Geeky's therapist takes it. Stay tuned.
Well, once we get moved to Florida, I can get you one that's totally down.
There we go. All right, so I got a question here. Cube Queen. Complex trauma often equals disengagement, isolation, often equals unemployment, poverty. How are the people that most need the therapy going to be able to afford it?
Yeah.
Great
So
question.
the reality is, under the current everything, there's no eloquent way to say it, but the reality is it's going to be more of the same. The same folks that can afford the $80,000 a dose cancer drugs are the same folks that are going to be able to afford this. Another way of stating that, the people that can't already afford experimental treatments are not going to be the people that get this. So what really needs to happen is widespread integration and acceptance of these therapies to make them a standard part, or at least a
Standard of
frequently
care.
encounter.
Yes.
Exactly. And that's really what that's really what's at the heart of this paper, is trying to develop what the standards of care should be.
Yep.
Because realistically, that's the only way you're going to get it as part of any developed society, whether it be socialized medicine or private healthcare. It doesn't matter. It still has to be approved by somebody wearing a shirt.
Right.
You know?
To go on that point, I mean, so for example, right, I take care of patients with MS. The rich ones are on fancy drugs, and MS progress is greatly, it's the symptomology doesn't develop as rapidly. They can go a very long time and almost means nothing, but their drugs like $80,000 a year.
Yeah.
The people that are on the
Case average.
basics, right? Yes, the people who are on the basics, it progresses more rapidly. See it every day. It's not cool.
There's a reason. There's a reason that mortality rates and comorbidities follow very closely the poverty lines.
Oh yeah.
And the socioeconomic divisions. There's a reason why the top 10% earners are generally, living years longer than the bottom 10.
Yeah.
It's not great. It feels horrible saying that, but that is the reality.
Oh yeah. I see it every day. I can just look at the old person and they're going to tell me what they did. They're going to tell me their whole life story a lot of times. I can just look at them and look at their basic health history, and I can quickly tell what socioeconomic background they come from. Just healthier, just had less. I mean, if it's nothing other than if you come from a life of affluence and you enjoyed that life your whole life, you still had some, you had to go through some shit. Nobody gets out of life alive, but just the general cortisol levels are lower, right? You're just less stressed out. You have more resources. You tend to make better decisions. Like, Yeah, we're not, I mean, this podcast and me, Dr. Rick, nobody here is going to change a truth that's been around for 5,000 years, which is rich people got it better than poor people.
Yeah.
It's how it is. Every day, I can't tell you how frequently I take it. We have a big Amazon hub here in near Akron, and I cannot tell you how frequently we take care of people that work there who have overuse injuries. Oh, my
Oh,
shoulder.
we
Oh,
have a
my
big
elbow. Oh, my
steel,
hand.
like steel power tools. They have a
Yep.
big steel plant here. STIHL. Yeah, same thing. The workers' comp is nuts.
Yeah, because they don't
And
care.
Boeing.
That's
But
why,
again,
yeah,
the people at Boeing get much better results than
right.
the people at like Dollar General.
Of course. Yeah. That's why, guys, when the robots take all our jobs on one level, that'll be good. We won't be slaves anymore. But they'll find a way to make us a slave. Don't worry. Let me see what else we got here.
I saw one comment. Yes, I am a Navy veteran, and especially for this week, go Navy, beat Army. That's specifically why I
All
wore this.
right.
It's Army week.
So is that where your money's on Navy? Or are you just saying that because you were in the Navy? Who do you think's going to win?
Every year, man. Every year.
Okay. All right. You guys want to get in on
No,
the?
but yeah.
No, I'm kidding.
No, I don't think we're gonna do well this year. It's been a while.
All right. You never know. You never know. Hold on. I'm just scouring through here to see if we missed anything. Oh, here's a good question. I don't actually know. This might be state to state.
Yeah, I thought that too.
When I first started seeing my therapist a year ago, she gave me a spiel about having to report any illegal behavior that I tell her. Do either of you know about the legality there? I don't. I know if they believe you're going to be a threat to yourself or somebody else, that they have to report that. I didn't know about.
Yeah, they're mandated reporters. It's really going to depend on A, where you live, B, the individual therapist, and C, the individual dynamics of what's going on. Because regardless of where you live, if you're having issues with, if they know that there are young children in the house, and because of other issues, you pose a potential threat to the health and safety of that child,
right,
you absolutely say the wrong thing and CPS is going to be called. Right. So when in doubt, again, the unfortunate reality is err on the side of caution.
Man, I never even thought about that.
Yeah, and that's the reality.
Yeah, that if I go, yeah, I'm going to talk to my therapist about how I grow mushrooms in my basement, that if she wanted to, if to her mind that somehow that was a threat that she could do that, I might be looking into that a little bit more hard before I have that conversation. Great question.
But generally speaking, a good therapist should really only get involved when there is a reasonable and expected or potentially expected threat of harm to somebody else or yourself.
Yeah, that was my understanding. And definitely, I think like you said, it's situational. So one person might say they're growing mushrooms in their basement for their mental health, and the therapist might go, oh yeah, that's probably what he's doing, and it seems to be helping. And another person could say the exact same thing, and they could go, I don't think it's helping. And I'm now starting to worry about how often you're doing that. Are you taking care of the kids when you're tripping? All this kind of stuff. So yeah, I would agree that that's not like one answer to that question.
Correct.
Yeah. All right. I think we're hitting, I think that's all the questions that I saw. All right. All right, so we got page 6 into this out of, I think it's 18 pages. Anyway, in the comments section, let me know if you guys want to do more of this, if you guys like this kind of stuff. I definitely, if Geeky's sitting over here thinking this is stuff we should be talking about, and you guys are all like, oh my God, just bring back a cultivator, just tell me. It's cool. I mean, I'm going to do whatever I want anyway, but I'm definitely going to try to, I want to serve the needs of the community and what you guys want to hear about. So you are always welcome. People send me podcast ideas pretty frequently. And I pursue many of them. Oftentimes I can't make it happen. The person they want me to bring on or what have you doesn't work out. But yeah, feel free. Let me know what you think about the stuff. If there's a therapeutic integration specialist that you know of and you want to see me talk to them, we can do that. Feel free to send that stuff in. Also, let me know if you guys like just this journal club concept. Do you like, the idea of me and Dr. Rick or me and somebody else talking about a new paper, kind of deciphering stuff like that? I think it's good. I think it's topical. I know like Fresh Cap Tony, he does a pretty timely podcast where he's talking about news of the day, covering the major points. I think it might be cool to do more of this with the science. I think there's a fair amount of people who really like getting into this stuff. And I look at it like this: the more people that I got talking about this stuff, the more people who can crunch through and understand some of these papers, who can go out and be advocates themselves, the better, right? If we show this podcast and 400 people watch it and go, oh yeah, that was a cool paper. And now in conversation, when this stuff comes up, integration therapy, you can go, yeah, there's a new paper. Yeah, I'll go check out the podcast, the links, the link to the papers there. That's good. That's what we want. We want all of this community more educated, more knowledgeable, more capable. That's what we're going for. We want to be respect-worthy community. We want to be behaving in a respectful way, which is why I keep advocating for ethical behaviors from vendors and from people in the space. Let's keep it up. I've had a few comments here. Dr. Rick, favorite guest. I hear this a lot. I can't, by the way, Dr. Rick, I maybe I've told you this. To this day, I will frequently get people message me and say, man, that Dr. Rick episode just changed everything for me. Man, I can't tell you how many people thought they were doing the right thing, but had this little voice in their head that were worried that it wasn't, or that they were making it all up, or that what do they know? And then they watched that episode and everything felt more right. So can't thank you enough for that. I get to hear these people tell me this all the time. I imagine you also hear a fair amount of it. But what
I
you're doing
because I don't get to talk about this stuff with everybody.
Okay.
Or with anybody except for like you and a handful of people. So
yes, they do.
I really
they
appreciate
love it.
it, guys.
They love it. They love it. They love it.
You
You doing this is very important. It's very significant. I cannot commend you enough.
I appreciate it. And just on a personal note, thanks. You know everything that's been going on with me, so thank you for making me get out of my shell.
It's all good. It's all good.
Yeah, thank you.
Know. Yeah, you're welcome. I get that way too, man. I do the same thing. You get in your head. You got a lot going on. You go, I can't do that today. Or, oh my God, this happened. But I need time to implode about this. And this podcast and growing mushrooms also, right? The mushrooms don't care what's going on in your life. And
yeah.
There are times when I get in trouble for this because they are needy little children. But it's good. It grounds you, but it also keeps you on a task. I mean, in general, and cultivation is a good therapy, right?
Yeah,
is a good
it gets
therapy.
you. It gets you out of those thought loops. It makes you
Yes.
concentrate on something. It makes you, because you can do it half-assed, but more often than not, you will be bitten in the ass for doing it half-assed. So you like
Right.
actually have to concentrate on it, which is
Yes.
liberating of sorts.
Agree. Yeah, I mean, it's kind of like a zone activity. It's good.
Yeah.
I like it. And man, it's great to work. This is the other thing, right? And you know that I think you get this a little more as a surgeon than say an ER attending gets. The ER attending figures out what the problem is and then bye-bye. And you never know the clinical outcome. Sometimes they snoop and keep up with it and all that, but they never really know. Whereas you go in, here's the brain trauma, I'm doing the surgery. Thank you, doctor, you saved my life. You actually get that gratification at the end, right? Or now with your cannabis practice, people have a problem. They come to you for their
Yeah.
card and all that, and they say, thank you, you made me better. Some people have jobs that don't work that way. It's like, what'd you do today? I don't know. I mean, I did a bunch of meetings, but I don't necessarily know what I did. So those like obvious wins are for people who have jobs like that, growing mushrooms and going, look what I did. Here's the mushroom. I grew it. That's great. It's nice to have that.
It's hugely satisfying.
Yeah. And it
Well,
never
thanks,
gets
guys.
old just showing off a grow.
Yeah.
It never gets old, man. Oh my God. It never gets old. I love doing it. All right. Well, thank you so much for being here. Really appreciate it. Won't be the last time. Hey guys, if you know of a research paper that you came across and you're like, this looks important, I don't know if I know what it frickin' means, send it to me. I probably won't either. I'll send it to Dr. Rick. Hopefully he can decipher some of it. I got a few other people I could send it to, and maybe we can have them on and talk about it. I think that would be great. There is research out there that is happening right now that is super important, but unless you have that person that can tell you why it's important, we might not be able to figure it out. So feel free to, send me stuff. I'll take a look at it, try to figure out who we can get on to talk about it. Again, I want to thank Dr. Rick for being on. Appreciate you. Glad I could pull you out of your shell and your the local turmoil of your life right now enough to take some time on this. Really appreciate it. You got to show off your surgeon's cap, which is very cool. Love it. Promote the Army. It's all good. All right. Thank you so much. Really appreciate you. Oh, the Navy. I'm sorry. The Navy. There's a difference? No, I'm totally messing with you. I'm sorry. All right. Love you, man. I will talk to you soon.
I love you too, guys.
All right.
Thanks. Have a great night, guys.
Yeah. All right. Here we go. Did the live. Guess what? I mean, we only had 4 technical difficulties. That was good, right? All right, guys. Thank you so much for tuning in. I hope you guys learned something. If it was remotely interesting, the link for that paper is in the description. Back from the rabbit hole. There it is. You can read it. This isn't like, 5th year organic chemistry. This is digestible. This is a good read. So check it out. See what you think. Ask me questions. Ongoing debate in the podcast channel on my Discord server, or just in the comments on the YouTube channel and Facebook, wherever you want to engage. I think it's great when we get to talking about this stuff. So hopefully we've generated some interesting things to continue talking about. If you guys got ideas for other things you want to talk to Rick about, send them my way. We'll get into that as well. Until next week, go grow some mushrooms. And then this is the part where, because we're live and I have not queued up the end card, you have to wait for it. Here we go.